everyone, I'm your host Maria Cozette, and today we have an exclusive interview with Dr. Grigor Harutunian. He's a board-certified neurologist and neurophysiologist that diagnoses, treats, and manages stroke, multiple sclerosis, neuropathy, pain syndromes, to name a few. How are you, Dr. Harutunian?
Doing well, thank you. Thank you very much for having me here today.
Of course, a pleasure to have you here.
Thank you.
And we have a lot to discuss.
Absolutely.
So we're going to discuss and focus a little bit on dementia and Alzheimer's, which is a common type of dementia. So I know that it usually occurs after the age of 60. Is it hereditary?
About 5 to 10% of cases are. The rest are sporadic, meaning they just show up, nobody knows really why, after usually in the 6th decade.
I see.
Yeah.
I see. And what are some common misconceptions people may have about dementia?
There's a lot, actually. When people present, especially older patients who are having memory issues, to them, every sort of memory problem to them is the onset of Alzheimer's disease. Right. And that couldn't be further from the truth, because there's 3 different types of memory. You have what's called a motor or a procedural memory, and then you have something that's called a declarative memory. And all of this stuff is housed in different parts of the brain, mainly the temporal and the parietal lobes. Everyone's heard of the hippocampus. That's like the memory store, so to speak, basically. And patients with Alzheimer's have more issues with short-term memory.
I see. They
have problems with not so much procedural. If somebody knows, let's say, how to put together some keyboard or put together a computer or work on a computer, that's something that's motor memory, and that will never go away. Well, end stages, yes, but in the beginning, that stuff never gets affected. People have more time short-term memory. They forget conversations the day before. They forget that, a family member came over.
I see.
Stuff like that. More within 3 days, 4 days time, they're having more issues with that, basically.
So with that said, what are some of the initial symptoms that people experience?
So memory deficit, that I already spoke about. There's issues with language. Even people have trouble naming stuff. Okay. And you see this more with naming. People have word finding difficulty. They're like, oh, simple stuff, not like a complicated word. Like they might forget what, a pen, like, oh yeah, you write with it, but they can't give you the word.
Right. So things they may commonly use.
Absolutely, yeah. So,
okay.
so it's called anomia, inability to name, pretty much. And that specifically is, again, housed in parts of the brain that in Alzheimer's patients tend to degenerate a lot faster than the rest of the brain. So language, mainly with naming, your declarative memory, mainly with short-term, specifically that. Patients could have cognitive or mental status changes where they are not, so to say, confused, but to family they seem kind of far off or away, kind of
right, like disoriented,
not at home, basically, in a sense like that. So, they say, my mom or my grandpa or my grandma is sometimes like staring off or is not communicating, answering questions, then she comes back. So stuff like that. And then, you could have neuropsychiatric symptoms too, mainly patients having personality changes. Your grandma or dad or mom could be the one type of person their whole life, and then you see them changing, which is a little unusual. Like this person's been kind, nice, and then they get agitated and angry, and it's unusual for them. So they're all hints, basically, that something is brewing, something is not right, because these are not normal for any age. You know what I mean? People say, oh, you're 70, that's your memory's that, it's just you're 70. You know what I mean? But yeah, there's memory problems with age that are normal for age, but when it's accompanied by the rest of the stuff we just kind of mentioned, it's never normal.
I see.
Never normal.
And it is very difficult for actually not only the individual suffering with these symptoms, but also the family, of course. So what are some of maybe the first steps that someone should take when they, notice that their loved one is going through such a thing?
So, generally most of these patients end up to their primary care doctor just because they bring it up to their primary, and their primary should, they could say, oh, you have dementia, but dementia, like I said, it's such a general term. Alzheimer's is the most common type of dementia. There's so many ones that come after, and if we have to talk about those, it'll take us like multiple shows, basically, but Alzheimer's is most common, and just because somebody's forgetting and having these, you cannot say, oh, you have Alzheimer's disease, here's a medication or two, I'll see you in like 2 months. No, to do to do justice to the patient, you refer them to a specialist and a neurologist, basically, so they could go through not only an examination, a neuro exam, and more of a mental status exam,
I see.
A cognition exam, an exam of executive functioning, things that a primary is not going to get into,
right?
Basically, or does not want to get into because you know, they're concentrating on the patient's primary issues, not so much the.
And that's why you're there.
There you go. That's
exactly.
why I'm here. Yeah. So you know, that's something where, you know, you evaluate, and then if the neurologist feels like, you know, you're showing certain signs, symptoms of Alzheimer's. Alzheimer's remains a clinical diagnosis, meaning, you know, basically the physician talks to the patient, examines the patient, comes up with a diagnosis. There is no blood test uniquely that's going to say yes or no. Yeah, there are imaging studies, we'll get into that a little later, that can help the diagnosis, but at the end of the day, Alzheimer's really remains a clinical diagnosis.
I see.
Yeah.
And what are some treatment options that patients can seek?
So it's interesting because in Alzheimer's brains, the neurotransmitter, the chemical in the brain that helps aid memory is acetylcholine.
Okay.
And there's so many of them. Everyone's heard of dopamine and serotonin and all this stuff, but acetylcholine is really active in certain parts of the brain, like the hippocampus, which is a store of memory, a processor of memory, along with the medial part of temporal lobes. In your temporal lobes, you always have you know, your body's in even halves, basically. You have two temporal lobes. One's here and one's basically here, and both of them house that parts of the brain that basically support memory. So acetylcholine starts to diminish in patients with Alzheimer's. So what you do is you give them medicines that are medicines that are going to inhibit the enzyme or block the enzyme that's going to break down acetylcholine. So what you're really trying to do is save or increase the remaining acetylcholine in the brain so it could do its function and aid memory.
Interesting.
So that's the main points of a lot of the medications that have come out. And there's about 5 or 6 of them that are commonly prescribed by, you know, clinicians for dementia or specifically, yeah.
Right. What are some preventative tips or measures that, you know, maybe people can either, you know, nutrients, vitamins, of course, eating habits, some things that you may suggest as a physician?
You know, it's very interesting you bring that up because there's been studies with vitamin E.
Oh, really?
Vitamin E in mega doses has the same effect as some prescription drugs.
Wow.
Believe it or not. Yeah, because it has the same effects on that acetylcholine pathway, basically. Preventatively, it's a little, there hasn't been proven trials that, you know, nobody who's like young and without any symptoms preventatively goes and gets into a trial and takes medicines, and then they follow them until they're 75 and say, hey, this person, it's hard to prove it. You know what I mean? It's going to be very hard. So will vitamin E, let's say at our age, or even, you know, like whatever, your whole life taking it, help? It's not going to hurt. The vitamin E is not going to cause you harm unless you take ridiculous doses of it, you know what I mean? But if you take what's recommended, they recommend about 2,000 international units a day of vitamin E. You know, if you take that, is it protective? I mean, it helps when you develop it, so I can imagine that it might help prevent it, but to answer your question perfectly, there's no specific preventative measures yet for Alzheimer's because A, we don't know what causes it, the sporadic type. The genetic type, yeah, they've identified the exact genes that cause the genetic form, but unfortunately, the patients who have genetic type, they develop in their mid-40s.
Oh, okay.
They develop Alzheimer's in mid-40s, you'll never see in a non-genetic case. It's usually after 65, 70. Yeah.
I see.
Yeah.
And so because you diagnose, treat, and manage a number of different neurological disorders, it's just interesting to me, in your field, have you noticed a particular prevalence in a disorder in recent years? Just from
any
the
disorder,
patients. Yeah, any disorder that you treat.
Disorder. I seem to see that migraine headaches seem to be really prevalent. Well, this is a fact that it's more females, but if you want to talk about specific races, is that kind of what you're referring to?
Yeah, or from your experience, or, you know, from the patients that you've seen in your field.
Caucasians, the wider population, seems to be suffering more from primary headache disorders, which under that fall tension headaches, cluster, migraine, very common more in the white kind of Caucasian population. I tend to see more strokes or vascular stuff in the unhealthy population, you know, and people who don't really kind of follow a thing. And unfortunately, like, I'm Armenian myself, and the Armenian culture, for the most part, especially the older generation, are not the very healthiest people. So I see a ton of stroke, may it be due to, you know, most commonly high blood pressure. Most of these patients have diabetes, they're smokers. You know, all of this combination leads to that, basically.
Right. And what are the tests that, you know, patients can seek to schedule at your practice?
A bunch of stuff. So I treat everywhere from simple stuff like headaches, you know, all the way to epilepsy and seizures, all the way to strokes. And for all of that, there's different tests. For instance, if you suffer from seizures, not just seizures, but any kind of confusional states, or, you know, like the family states that, you know, the grandmother is kind of like out of it at times.
Right.
An electroencephalogram, which is almost like an EKG for your brain, it measures waves, brain waves, and it's way different than an MRI or a structural test of the brain because it records brain waves. And abnormalities in their brain waves can tell you about if the patient's having seizures that you can't tell by just looking at them, if there's certain slowing somewhere. EEG, before MRI was even invented, was like what was used to find stuff in people's brains before MRI was done. But EEG still has a huge, you know, use in stuff like that. Transcranial Dopplers, it's a special ultrasound for your brain, especially in my stroke and dizzy patients.
Right.
Do that. And also a lot of nerve issues and muscle issues. I do EMG nerve conductions too, and that's finding out if people come in with numbness, tingling, weakness, like, you know, a lot of diabetics have this. You can figure out which nerves are affected by doing a special nerve and muscle test to check the integrity of the nerves and the muscles, basically. So it's a different variety.
Yeah. So in a little bit, we're going to actually watch a clip because you made an appearance and an interview on Channel 7 News. But before we do, I know that people out there would like to know what first inspired you to become a physician?
You know, most people say I had a family member who was a physician, not me. I did not really have anybody in the family that was a physician. To tell you the truth, I tried my hand at different professions and I did not like it. Not that I actually practiced it, but I actually went and hung out with people who did that profession. I had friends who were in it, older than me. And I just saw that it just doesn't suit me, it doesn't fit me. And then when I kind of started reading more about medicine and just the way the body works, and then the body just kind of fascinated me, because a lot of people take the body for granted, but it's seriously a very, I would say it's probably the best invention, whatever you believe in, whoever invented it, it's the best invention that we ever had and will ever have in the future.
Truly amazing.
Whoever invented the body with the whole associations and connections is truly amazing. So that in itself, you know, to be able to understand the body, to be able to treat people with the body, it kind of...
Specifically the brain, I would say, is absolutely fascinating.
The brain is the body's last frontier. Because most other organ systems, we really figured most of it out. We really have. You know, the brain remains such an intricate aspect, and I really think in our lifetime, in the next 30, 40, 50 years, we're going to see the most advances in brain disease, brain and spinal cord, just because there's so much unknown.
Wow. Would you like to set up your interview on Channel 7 News?
Absolutely, sure. So Channel 7 came to me regarding the recent suicide of Robin Williams, and it was specifically about how the diagnosis of a neurodegenerative disease, which Alzheimer's is one. Neurodegenerative is just a general term saying brain deteriorating, in a sense, Parkinson's is another neurodegenerative disease that could, you know, change someone's life completely, you know? I mean, they're otherwise doing okay, and then they get Parkinson's, they get all these symptoms, and then life completely changes. So Robin was already suffering with depression, and then that diagnosis of Parkinson's, I think, just put him over the top. And possibly could have led to his, you know, suicide. I don't know much about his other social aspects of his life. Obviously, I don't know him personally, but, you know, that's something that could have put him over the top and potentially led to a suicide, you know, because Parkinson's, I mean, you know, if any one of us develops Parkinson's, that will give us a sense of depression or, you know, sadness as well, because, you know, nobody wants a neurodegenerative disease. So interviewed with Channel 7 regarding just some aspects of that.
Wonderful. Well, let's check it out.
Health specialist Denise Tador joins us with a closer look at this disease that impacts millions around the world.
It does so many people. Parkinson's disease happens when nerve cells in the brain don't produce enough of an essential chemical. Again, it has no cure. For many, it can be a devastating diagnosis. In time, this disorder robs people of their ability to multitask, react quickly, and think fast.
I do voices. Yeah! Look at me right now, Moneypenny. I want to undo that bow and get to know you.
I'm ready to make a deal with you!
Rapid-fire improv is a talent Robin Williams is famous for. Now we've learned the comic genius was faced with a neurodegenerative brain disease that would, as it progressed, ultimately slow him down. Neurologist Grigor Harutunian says Parkinson's disease attacks the body's connection to the brain's main control center.
The brain tells your arm to do something, and because of that dopamine transmission is slow, it takes a while for you to get that. And all these symptoms come because you're starting to lose dopamine.
The goal of medication and therapies like deep brain stimulation is to replace the low levels of dopamine. 10% of cases are genetic and occur in younger adults. 90% of Parkinson's cases have no known cause and develop when people are in their 60s.
Symptoms like trembling, slowness of movement, stiffness, and loss of balance and coordination can begin gradually. Medications can help delay the onset, but doctors say in high-functioning people, the symptoms can be much more noticeable sooner.
You're slow in multitasking, you cannot do things as fast, you cannot process information as fast, your thinking slows down.
Studies show major depression is present at any given time in 20 to 40% of Parkinson's patients. Dr. Harutunian says the key to helping newly diagnosed patients is to tell them what to expect, to help them understand how the disease will progress. But in people with a history of depression, a Parkinson's diagnosis can worsen the depression.
And Parkinson's is a big stressor. Parkinson's can be a huge stressor, especially someone who's battling depression. Absolutely.
But Dr. Harutunian says he has many patients diagnosed with Parkinson's who lead full, active lives many years after diagnosis.
It's not curable, but definitely very manageable and treatable.
The presence of a tremor is a classic early sign, but not all tremors indicate a person has Parkinson's. One characteristic sign, though is an involuntary movement that doctors call pill rolling. It looks like a person is rubbing their thumb and their index finger together as if there's a pill in between them. It's found in about 70% of those with Parkinson's. Again, early detection is key in managing this disease, like in many conditions like it.
All right, Denise, thank you. And our
We're back. I'm your host, Maria Cozette, and my guest here today is Dr. Grigor Harutunian, a board-certified neurologist and neurophysiologist. So we've had a very informative interview, and yet we have so much more to discuss. I did want to emphasize that it's very important, and there's a big advantage to seeking a young physician because they're very tenacious about research and insightful about the latest advancements in medicine. So with that said, there have been a lot of recent advancements in neuroimaging. So I wanted to ask you what your thoughts on the AMIVID study.
Yeah, it's actually it's a very, very cool adjunct, I think, to helping diagnose patients with dementia, because like we touched on before, Alzheimer's is not the only type of dementia.
Right.
There's so many other different ones that actually each dementia has its unique predilection for a specific lobe of the brain.
I see, okay.
There's even dementias that are actually called frontotemporal dementias because those are the lobes that degenerate. And their name just tells what the disease is, basically. Alzheimer's tends to affect your temporal and parietal lobes, basically. And these studies that have come out, the main pathology of Alzheimer's is that your amyloid beta amyloid protein gene is not functioning correctly.
Right.
And it either overproduces beta amyloid or it does not get rid of enough beta amyloid, does not recycle it, does not break it down. Whatever the reason, this stuff piles up in the brain, becomes chunks and starts depositing in certain parts of the brain. These deposits are what cause pathology because they're abnormal deposits. They should not be there in the first place. So if you have one of these abnormal plaques sitting in your hippocampus, guess what? Your memory is going to be shot because you have an abnormal thing, plaque sitting inside your hippocampus. Right. Now, what does these imaging studies do? They use a radioactive isomer, basically an agent that is injected, and it has a predilection for these beta amyloid plaques. So it goes and attaches to them in a very kind of intricate immunologic kind of way, attaches to them, and then the study can, when you take the patient's imaging exam, these areas light up. So almost like a Christmas tree, you get like beta amyloid stuff that lights up. And if you see at least a mild to moderate amount, or obviously more than moderate, then you can use that as evidence and the patient's clinical symptoms, like, presenting with what sounds like dementia, to make more of a comfortable diagnosis of Alzheimer's, because the true diagnosis of Alzheimer's still remains on autopsy, where a lot of families don't opt for autopsy. They don't want somebody just cutting into, their family, just want to bury, their family member without an autopsy, obviously. So the ones that have autopsies, they've actually found these plaques in the brain, multiple deposits of these plaques in the brain. That's what kind of gives you diagnosis. But these imaging studies are great because they could give you, in a live patient, kind of like supportive documentation that help, like something is going on here with these plaques.
Right.
Yeah.
What are some of the causes for Alzheimer's? Is it traumatic brain injury? Is it, maybe someone that suffers from multiple sclerosis may also, what are some of the kind of causes for it?
So nobody knows specifically what causes Alzheimer's to begin with, but there's a lot of causes of dementia, because dementia, like I said, is a very general term.
Right.
Just like a headache can be caused from 50 different things, you being dehydrated, not sleeping enough, having a brain tumor, obviously it's just a bunch of...
Of course, yes.
Dementia also has a lot of things under it. So sure, MS, any disease that has effects on the brain, a neurodegenerative process like multiple sclerosis, Parkinson's disease, eventually the circuitry that gets haywired from whatever that neurodegenerative can lead to dementia.
I see.
And dementia is just cognitive deficits, cognitive loss, basically. And all that falls under that, falls memory and concentration and, just being able to go through life, like basically. So all that stuff gets affected. So is there a specific cause? Like, is there a virus, let's say, that causes Alzheimer's? Is there some kind of bacteria? Is there some, nobody knows. Nobody knows what triggers that gene to go haywire and end up overproducing and not recycling enough amyloid in the sporadic case of Alzheimer's. Genetic-wise, yes, because the gene that controls that protein enzyme is malfunctional. So it's not controlling that protein, so that it's not getting the input, the normal input, so it's just haywired and just that's genetic though. A lot of the 70+ people that have normal genes, it's not the gene, it's something past the gene that's caused that protein to... And that's when I say advancements in the future. I don't doubt that in our lifetime, they'll find what that trigger is, and I'm going to be very so how interesting is that going to be? Like, oh, wow, was that all along? Or who knows, you know what I mean? And then they'll be able to prevent it, vaccinate it, who knows? You know what I mean? So it's very, very, very interesting.
Hopefully.
Yeah, no, absolutely.
So with regards to the treatment of it, what are some of, you mentioned there are, typically some medication that's prescribed. What are some of the medications?
Sure, they all fall in the similar class of acetylcholinesterase inhibitors. Acetylcholinesterase is the enzyme that breaks down in the brain acetylcholine, which is the chemical that's lacking in Alzheimer's disease.
Right.
So if you block the enzyme, it won't break down acetylcholine. If it won't break down acetylcholine, there'll be more of it around to help support memory and help slow down dementia. It's not going to cure it, you know what I mean? It's more to stabilize the progressive decline so patient just doesn't, in 1 year, just go straight down. Just kind of decline, maybe give the patient another 8, 9, 10 years of somewhat of a functional life. It's not going to be normal, but... So, a lot of names that most people, on this have heard is Aricept, which is a huge market. The pharmaceutical company that made Aricept, it's, so out there, everyone uses it. Aricept and Namenda.
Okay.
These are, Aricept is an acetylcholinesterase inhibitor. Namenda works a little different because it stimulates certain receptors in the brain, NMDA, and tries to positively excite the parts of the brain that are dying, to try to give it the last hurrah to keep it going, basically. And that's how Namenda kind of works. There's also other ones like Exelon and all these other ones, but they all work similarly to Aricept and Namenda. And generally, you don't want to give someone just one because usually combinations of 2 different classes of medicines work the best because they're synergistic. They complement each other.
Okay.
So you want to, combine them together and then try to see, which one. I mean, try to see, how much of an effect that it has. And
with and you said it perfectly, actually. As far as the effectiveness goes, what are you looking for as a physician in your patient to see how effective this particular medication is for that individual?
So improvement in short-term memory, not curing, not normal short-term memory, but improvement in short-term memory. The patient now says that, I remember what I had yesterday for breakfast, or 4 days ago some family member came over. I remember my conversation with that family member, things like that, like, okay, whereas before, nothing. Language, naming gets a little better. although that's less likely to respond, people are not having some of those word finding difficulties, like, oh, what is that called? It becomes kind of normal, not normal, but it gets better. And then they're not so confused or cognitively kind of impaired, like they're not out of it, basically, so to say. So stuff like that if, family members are the best people to notice because they see that patient, every day, and they know how they were before medicine and they see what they are after medicine. So
I see.
Yeah.
Well, thank you so much for coming. Such an insightful and informative interview. Any remarks you'd like to tell the viewers?
Well, first, thank you again for having me on the show.
Oh, my pleasure.
I was happy to kind of give my 2 cents on dementia and stuff, and it's pretty prevalent. So, if you feel like you're having symptoms or your family member is having symptoms, then an evaluation promptly is more important than just waiting, because early treatment can mean a difference.
Yes, definitely. And truly proud to have a young Armenian-American physician. So for any further information, please visit laneurology.com or, of course, call the number on your screen to schedule an appointment. Thank you so much. Thank you.